Hi, Dr. Turner Bicknell. This is Corinne Scott from Section 001, and this is my remediation for Exam 2. So my first slide is about ethical dilemmas. So an ethical dilemma is something that is a problem during a decision-making process where you have to pick between two possible solutions that may not be considered ethically correct. So, an example of this could be that a nurse has a patient who has cancer and they had just gotten a biopsy on their tumor to see how far along the cancer was and what stage it was in. And the nurse could feel that the information was too hard to handle. So instead of saying, "Oh, we just got your lab results in, your cancer has been benign or malignant," she could say, "Oh, we don't have anything yet," and this would be a violation of the ethical principle of veracity. Next, I will be talking about skin lesions. The first skin lesion I have is a macule. So a macule is a lesion that is less than 1 centimeter in diameter, and it has circumscribed borders, and this can include a freckle, a flat mole, and petechiae. The second skin lesion I have is a patch, and sorry for the typo. A patch is a skin lesion that is greater than 1 centimeter in diameter. It can have irregular borders. An example of this would be port wine stains and ecchymosis. The next one is a papule. So a papule is a skin lesion that is less than 0.5 centimeters in diameter. It is palpable and it does have a circumscribed border. An example of this would be an elevated nevi, a wart, and lichen planus. Continuing on, we have a plaque. A plaque is a skin lesion that is greater than 0.5 centimeters in diameter. It is also palpable, it is deep, and it will be firm. An example of this is psoriasis and actinic keratosis. The next one is a nodule, and a nodule is a skin lesion that is 0.5 to 2 centimeters in diameter. It does have a circumscribed border. An example of these are lipoma, squamous cell carcinoma, and a poorly absorbed injection such as a shot. Continuing on, we have a tumor, and a tumor is a skin lesion that is 1 to 2 centimeters in diameter, and it has a sharp border but is not always present. So this means that it can be symmetrical with a border, but it also can be very irregular. This includes a large lipoma and a carcinoma. So now I will be continuing on with skin lesions. The first one on this slide is a vesicle. A vesicle is a skin lesion that is less than 0.5 centimeters in diameter, and it is filled with fluid. An example of this is herpes zoster virus, varicella, poison ivy, and second-degree burns. Next, we have a bulla. A bulla is a skin lesion that is greater than 0.5 centimeters in diameter. It is also fluid-filled, and it includes contact dermatitis, large burn blisters, and poison ivy. Next, we have a pustule. A pustule is a skin lesion that is a pus-filled vesicle or bulla. So an example of these would be acne, impetigo, furuncles, and carbuncles. Continuing on, we have a wheal. A wheal is a skin lesion that is elevated with transient borders. They can be irregular in size and also irregular in color. They are often the result from the movement of fluids such as urticaria or hives and insect bites. And lastly, we have a cyst. A cyst is a skin lesion that is encapsulated. It is fluid-filled or semi-solid in mass. These are located in the subcutaneous or dermis tissues. An example of this would be a sebaceous cyst and an epidermoid cyst. Next, I will be talking about clubbing of the fingers and nails. So for clubbing of the fingers, the distal phalanx is rounded and bulbous, which results in a more convex nail plate. This can be classified as clubbed due to the fact that the angle between the nail plate and the nail fold is increased to at least 180 degrees or more. Another characteristic of this is that when palpated, the nail feels spongy. This condition can be caused by chronic hypoxia and lung cancer. Up next, I have pressure ulcers. So pressure ulcers are an injury in the skin and the underlying tissues that is a result of an excess amount of pressure in that area. When talking about pressure ulcers, it is important to remember the different stages that we can identify as nurses. The first stage is called stage 1, and it is an intact, non-blistered skin. There is a non-blanchable erythema, persistent redness in the area that is exposed to pressure. The second stage, called stage 2, results in a partial thickness wound involving the epidermis and or the dermis that does not extend below the dermis. The third stage, called stage 3, results in a full thickness wound that extends into the subcutaneous tissue but not into the muscle, bone, or connective tissues. So the fourth and final stage, called stage 4, is deeper than a stage 3 ulcer, so it has the full thickness wounds that extend into the subcutaneous tissue, and there is often exposure of muscle, bone, or connective tissue. The next thing is the Braden scale for pressure ulcers. So this is a risk assessment tool that is commonly used in nursing to determine a patient's risk for obtaining a pressure ulcer. So this scale considers 6 subcategories. This includes sensory perception, moisture, activity level, mobility, nutrition, friction, and shear. So starting off with sensory perception, when a patient has decreased sensory perception, this increases their likelihood of getting a pressure ulcer, as they may not be able to fully detect the pressure that their body is feeling. Next, we have moisture. If a patient is incontinent or is wearing briefs because they often urinate themselves, this increases their likelihood of getting a pressure ulcer. Next, with activity, a patient who is not active and does not move about may have an increased risk for pressure ulcer in comparison to a person who is much more active and can get up and move about. Continuing on with mobility, this one is very similar to activity. If a patient is considered immobile and they cannot get up by themselves and they are bedridden, they will have an increased likelihood for pressure ulcers due to the increased pressure over time as they lay in a hospital bed. Now let's talk about nutrition. Nutrition is very important for our body as we need it to complete daily functions and also daily protective measures for our body. If someone has poor nutrition, they are less likely to receive all the nutrients that they need, and this can increase their risk for obtaining a pressure ulcer. Continuing on with friction and shear, these are the two forces that tug and pinch on our body and our skin as we sit in a bed or move about. So if a patient has to be moved manually, they are more likely to experience friction and shear, which increases their risk for obtaining a pressure ulcer. So now I would like to talk a little bit about the results of this Braden scale assessment. So anyone who receives a score of less than 9 is at very high risk for obtaining a pressure ulcer. Someone who is high risk scores a 10 to 12, someone who is a moderate risk obtains a 13 to 14, and someone who is considered at risk obtains a 15 to 18 on the Braden scale assessment. So now I would like to switch our focuses over to urinary system. The first slide I have discusses urinary retention. Urinary retention can be defined as the inability to empty the bladder. This can be a result of a numerous number of things, such as childbirth, infections of the brain and spinal cord, diabetes, stroke, neurologic disorders, heavy metal poisoning, pelvic injury or trauma, prostate enlargement, infection, surgery, bladder stones, bladder tumors, rectocele, cystocele, constipation, urethral stricture, and medications. So some interventions for urinary retention include increasing the fluid intake. This will encourage the bladder to excrete all of the fluid that a patient has taken in. Secondly, we have Creed's maneuver, which involves the massaging of the bladder to encourage the bladder to excrete urine. And finally, if none of these have helped and the patient is still experiencing urine retention, we can catheterize our patient as long as we get an order from the primary care provider. Continuing on with our discussion of the urinary system, we have urinary incontinence. This can be defined as the inability to control the passage of urine. This can be intermittent or complete. This most commonly affects people with diabetes, people who are obese, young children as they have not learned how to properly control their bladder, and elderly patients who have lost muscle strength to hold their bladder. So as far as the types of urinary incontinence go, we have 4 main types: stress incontinence, urge incontinence, mixed incontinence, and functional incontinence. So stress incontinence is a loss of urine control during an activity such as exercise that increases the intra-abdominal pressure. Urge incontinence is when you have a sudden urge to urinate and you don't have a sufficient amount of time to make it to the toilet. A mixed incontinence is a combination of both urge incontinence and stress incontinence, meaning that you often feel you cannot make it to the toilet, and during physical activities, when intra-abdominal pressure is increased, you lose the ability to control your bladder. And the final type of incontinence is functional incontinence. This is a complete lack of control that is not related to any abnormalities of the urinary tract. Instead, this is a result of a physical limitation, and this can be seen in children who don't understand how to control their bladder. When a patient has a urinary or a bladder issue that cannot be determined, many healthcare providers will order something called a bladder scan. It's most commonly used in patients with urinary incontinence, and this type of test can reveal what is causing the retention or the incontinence, whether it be an infection, obstruction, or neurological issues. The procedure is completed by a radiologist and is then evaluated by a urologist to determine the results. I have included a section from the Urology Care Foundation explaining what the procedure is like. Essentially, you'll be placed on a scanner table, your urethra will be cleaned, a flexible tube, also known as a catheter, will be placed and it will go up into your bladder. And then a liquid with radioactive material will be pushed through the catheter tube to fill your bladder so that you will feel the fullness. After this, the bladder will be scanned and the images are taken. You also may be asked to urinate during this test so that your doctors can view how the bladder empties, and images are taken when the bladder is full and then again after it is emptied. In continuation with our theme of the urinary system, we have a 24-hour urine specimen. So, a 24-hour urine specimen is an order that a care provider can give for a patient whose urine needs to be collected for a period of 24 hours at a time. This lab procedure can tell the doctor how much creatine is cleared by a patient's kidneys within a 24-hour time frame. So, the procedure is as follows. First, you must post a sign in the patient's bathroom. Then you will ask a patient to void, but then you will discard the first void. Then you will begin the collection after the initial void is discarded. Record the time and collect your urine for 24 hours. Once 24 hours has passed, you will collect a final sample to be sent to the lab. Before sending this specimen, the care provider will notify you of what preservatives, ice, or cooling measures will be needed in order to send in the specimen. The final topic that I will be discussing during this presentation is a sterile field. So a sterile field is an environment that is free of all microorganisms so that they're not passed on to a patient during a procedure. So before you set up your sterile field, you want to perform your hand hygiene. Introduce yourself to the patient, verify your patient using 2 identifiers, and then you're going to verify that the procedure requires a surgical aseptic technique. Then you're going to assess your patient's comfort level, oxygen, and elimination needs. And in order to prepare a sterile field, you need to begin by checking the expiration date on a sterile packaging. Look for any punctures, tears, and evidence of moistures. Gather the necessary equipment and supplies. Select and prepare a clean, dry workspace. and perform hand hygiene thoroughly using an alcohol-based rub or antimicrobial soap and water. So up next, we'll be talking about setting up a sterile field. So after you have prepared your sterile environment, you're going to ensure that the sterile kit, again, is still intact. You're going to place the sterile kit on the clean workspace, remove and discard the plastic dust cover, unfold the packaging per the manufacturing instructions, place the package on the work surface and position it correctly, grasp the outer surface, open the flap away from your body, grasp the outside surface, open the side flap, pulling it to the side. Now open the second side flap and pull it over to the side, which allows it to lay flat on the table. Keep your arm to the side and do not cross it over the sterile field. Next, you're going to grasp the outer border of the last innermost flap, stand away from the package, pull the flap back, and use the opened package wrapper as your new sterile field. And in this last side, we're going to talk about maintaining a sterile field. So a sterile object only remains sterile if objects that touch it are also sterile. So for example, if you touch a sterile object with your bare hand or with non-sterile gloves, you have to throw away the entire kit and start from the beginning. So to reiterate that, a sterile object becomes contaminated when touched by any non-sterile object. If your hands or a sterile object dropped below waist level, both of them are considered to be contaminated. A sterile field becomes contaminated if moisture permeates the field. Avoid reaching across your sterile field. Never turn your back on a sterile field, and never leave the room after a sterile field has been set up. If you do any of the following, you will have to start over and completely throw away the entire sterile kit that you had just opened. Another extremely important aspect is to make sure that your patient does not touch the sterile field. For example, children like to touch things, and they can often be curious and ruin the sterility of your field. And that is the conclusion of my Exam 2 remediation presentation. Again, my name is Corinne Scott. I am in section 001. Please email me if you have any questions, and have a great week.